Доброе утро. Почему-то никого не слышу.
Доброе утро.
Доброе утро, мы все на мьюте.
Hello.
Hey. Hello, hello. Do you hear us? Okay.
Hello.
Hello. Do you hear us?
What am I supposed to do? Cannot hear.
Hey, do you hear us? Abe.
Hi.
Hi.
Cannot hear.
I hear you. Okay. You?
You can hear me?
Let us check. Yes.
Yes. I cannot hear you. I cannot hear you.
Can you check? Let me.
Can you hear me now? Yeah.
Yeah. Yeah. Do you hear me?
I cannot hear you. Should I do something? Should I do something? Dimitri?
Yes. Just.
Yeah, I can see you. Select the speaker, I can select you, yeah. Please check on the right from the micro. On the left, on the bottom left, I have a microphone. It's okay. Small triangle to the right. Small triangle to the right. I have nothing on the right. I'm sorry. Ah, you're on the top. To the right. And sounds.
Do you hear us now?
Okay, it says micro integrated. Test. Should I do a test?
Yeah. Try to test.
Small triangle. Yeah, I've seen it. And sound settings to the right. Check your default system for sound is on. Yes, it is on. It was working. I had a conference just the other day. It was working. Maximum.
Yeah. We hear you perfectly well.
Now I can hear you.
Okay, cool. Super good.
Okay.
Welcome. Welcome to Moscow.
I realized what was going on.
Albeit virtually, but anyways.
Okay, great. Everything looks okay. And when I put my slides on, all I do is what?
I will stop sharing the program, yeah.
So, what should I do now?
You press the button at the bottom of the screen, which says share screen, and you choose what to share, which window to share.
There, can you see my presentation now?
Not yet. You need to choose what you want to share.
Ah,
The screen or the specific application.
I want to the slide.
So when you press the share screen button, it gives you a choice, a screen with a choice, whether you'd like to share your screen completely or some specific application. You need to choose something.
Let me try that again. It says share my screen. Okay, I click on it. Is that right?
Mm-hmm.
Okay.
And you choose what to share. Screen, whiteboard, iPod, phone, iPad, documents.
I have just an empty iPhone. I don't understand. Let's share here.
Yeah, it works now. We see your screen now.
You see my screen. Okay, so now if I put...
So if you put PowerPoint, yes, we will see PowerPoint. Correct.
Okay, I have to re-find my... Okay, so it's here. So now you can see?
Yes.
And if I go to... I have to go to...
You need to press F5 to start the presentation, full screen.
Yeah. Is this better? This is, now you only can see my slide,
No,
right?
you need to turn off presenter mode. Would you please press Escape?
Sorry?
Go out of the presentation.
Yeah.
Yeah, and then go to Diapanorama.
Yeah.
Diapanorama. And it has Lire la narration, maybe? Yes.
It?
Good this way. Oh, this way, yeah.
So you, okay, so now what I do,
You just click the mouse key or you use the buttons at the lower left of the screen. Professor Hutkov has joined, so with this, I'm handing over officially to Professor Hutkov.
Good morning, everybody.
So what should I do now? Should I just say it like this or? Dimitri?
I can stop sharing for now, and you will reshare when we hear the welcome speech by Professor Hutkov. With that.
Abe, I'm sorry, I need all the time when we begin any course, I need to say some welcome speech. So I want to say, everybody, I'm really happy to see you and all the participants, and I hope that there will be. I think it's good if so. It's like a characteristic of our conference that we don't have 100 or 500 participants or 1,000 or so on. So it's small amount of surgeons who want to write something which will be published in something also which have some value in scientific world. So I want to say many thanks to Abe, who helps us to be well known in scientific worlds in this because it's Abe who initiated us and continue initiating our activity in publishing of scientific articles in different journals. So I want to say thank you, and I think that it's not the first conference. I think it's the 5th. Yes, it's the 5th. So, and I believe that it's not the last, and they are very useful, and I hope that this collaboration will live in centuries.
Good.
So thank you very much. I will not take a lot of time from the audience, and thank you, Abe, again, and have a good time and productive time during this day.
Okay, thank you, Igor. Thank you very much. I see some faces on the top. Can I have an idea of how many people are online?
We have around 40 people online as of now.
I see a Dimitri Beresnev.
Yeah, we usually gather people in in Zoom only for those who are organizers, and most of the audience is watching on the medX Pro portal.
All right.
So they are on YouTube, Facebook, and medX. Okay.
I see Anastasia. Hello. I see two Anastasias. Ivanova and Gustas.
Yes, Abe, all these people that we are seeing the screen, they are from the organizing committee, and
all right, okay.
That the others, perhaps they will be because I know that Roman is, you know him, Roman and Ruslan, they went to other offices, to their offices to be connected, and I know that our residents, they prepared some articles.
Yes.
Last. So I understand that they will be connected a little bit later.
Okay, so that will be later. Okay.
Yes, perhaps you can start. I think that you can start with the presentation.
Okay.
Then and I'll so switch off my picture and I'll try to understand who is from our center.
Okay. So I go, Dimitri. I go back to share my screen, right?
Yeah, absolutely.
Okay. Is it working? Can you see a telephone?
Yeah.
Okay, great. So I will start.
Yeah, please do.
Can you see my first slide? How to write the nearly perfect manuscript.
Yeah, we can see it.
Okay, great. Good morning, everybody. I am very, very proud to be part of the program today. The essential part, as a matter of fact, because not many other people are going to be participating as speakers, at least. And I would like to call your attention to the fact that writing a manuscript for scientific literature is something that may seem easy for some, may seem difficult for others. But the essence is that we have to have first of all, an idea of what a manuscript should be. Second of all, what it serves. Third, that we have to abide to conventions, rules, in order to be sure, first of all, that the paper is accepted, but second of all, that the paper will be understood. So I would like, in the first part of our meeting today, or our conference today, go through what I think is very essential in the composition and then the actual writing. Medical writing, in fact, is a skill. Everybody knows what a skill is, I'm sure. You will know how to hold a basketball. You know how to shoot a basketball. You know how to, let's say, operate. These are skills. How to drive a car. Well, medical writing is a skill. The idea is to get a message across to the audience, and that audience is the readership, the person who's reading your article. It's like speaking in public. You can see that there's only one person looking at the speaker. The others, they're not interested. They're talking, they're doing something else. It's up to you as a writer to make sure that people understand that you are writing for them. You're not writing for yourself. All too often, writers of a medical paper write for somebody, their boss, their friends. That's not what the requirement should be. The requirement is to write for the reader. Keep that in mind. In order to get your message across, the message has to be credible, believable. We have to understand right away that we're talking about something, that the writer is talking about something that is true, believable. The best way to do things is to make sure that you write objectively, not subjectively. Objectively means, and we'll see it all throughout the day, facts, realities, no guessing. We don't want the reader to guess. We want the reader to know right away what's going on. The message has to be interpretable from the reader's point of view. And now I'm going to use a word that's very important. I don't know how to say it in Russian. It's called ambiguity. We have to have a message that is absolutely clear, objective, without any ambiguity. Ambiguity is something that, I'm sorry, I can't have an introduction with you. Is there anybody that's listening to me that does not know what the word ambiguity means? Is it possible to hear?
Yeah, absolutely. There's an equivalent in Russian, which is двусмысленность.
Okay. In other words, it's when I see a word, I understand exactly what that word means. It doesn't have a double sense. It doesn't have a shade. It's clear. I'll go through this again and again. The message has to be reproducible. Now, what does that mean? That means that everything we describe has to be not only clear, objective, interpretable without ambiguity, but the facts have to be described in such a way that if I want to do the same experiment, if I want to reproduce, I have all the information that I need to do so. Nothing is missing. Everything is there. So, let's look a little bit more in detail, or look at the medical writing from a different perspective. I like to compare medical writing to a goldfish. Everybody's saying it's not very gold. The fish is a little white, right? Okay. We need good facts, the data. We need good methodology in order for the facts to be credible, authentic. And then, yeah, okay, now we have a goldfish. Goldfish. The goldfish is therefore the contents of a paper. And those contents, we have to put it into a container, into the glass bowl. Otherwise, the fish doesn't live. There's a bowl, glass, that's the structure. And in that structure, in that bowl, we have water, which is going to be our medical writing style. Okay, everybody see the allegory. So, yeah, something wrong with my voice, I have to some water. Okay, so we have the contents going into the container, or to the glass bowl. And that glass ball has to be clear. The water has to be clear. The glass ball has to be clear, that means the structure has to be clear. The water has to be clear, that means the style has to be clear. So we can see the goldfish. If the water or the style, the vocabulary, the grammar, the syntax is not clear because of ambiguity, for instance, we can't see the fish, or we can't see it very well. So let's take a look now at that structure and the style. I'm going to start with the style. The first rule in medical writing style is based on three pillars. Precision, clarity, and concision. And you see that there's a sort of a priority, that precision is the most important. It should override clarity or concision whenever there's a conflict between the three. But you have to try to make sure that the three are all taken into consideration. Let's take a look in detail what these three pillars mean. First, concision. The easiest and most frequent mistake that we make is repetition. We repeat the same words in the title, in the summary, in the introduction, in the discussion. Every time I write a paper, one of the main goals that I have, not when I'm writing, but when I correct it, when I look it over, when I revise it, is to make sure that I avoid repetition, useless repetition. It's something we do all the time just by nature, human nature. I'll give you examples later on. All throughout the paper, whether it's in the title, the summary, or the abstract, the introduction, we have a tendency to repeat. We want to make sure that the reader understands, but you will understand that the structure takes care of that. We don't have to worry about it anymore. And very often we see repetition between the title and the summary, or in the introduction and then in the discussion, or repetition between the text, the figures, and the tables, or in the conclusion where we see results that or should be in results, not in the conclusion, or parts of the discussion. We will look at these in detail, but I just wanted to point them out to you as a start. So this is one way of avoiding, of ensuring concision, is to avoid repetition. Repetition can be repeating the same word in the same sentence. This happens. Or in two consecutive sentences. When you revise, or when I peer review, and I see the same word in two consecutive sentences, there always is a way to get rid of that repetition and combine the two sentences. You should avoid what we call introductory sentences. Introductory, can you see my arrow? Can everybody see my arrow? Hello? Hello? Can you hear me?
We can hear you.
Yeah? Do you see my arrow? Arrow on the screen?
Not really.
Ah, okay. you can see that avoid introductory sentences. You can see my text?
Yep.
Okay. Let me explain what an introductory sentence is. For instance, here, the example. Can you see my example? There are many ways to cut the skin. Second sentence, the most often used. I have a picture on here. I can't see my screen. The most often used technique to cut the skin is with the scalpel. Okay, you see two sentences and you see that there's an introduction and then the fact. Rather than saying it that way, all you have to do is the scalpel is the most frequently used technique to cut the skin. So you see I've reduced the two sentences to one just by avoiding the introductory sentence. The introductory sentence being there are many ways to cut the skin. The second pillar is clarity. Clarity means avoiding what we call verbosity. Verbosity is it may be, it may sound, it may, this is one of the ways. These are a lot of words. Verbosity means using a lot of words to say what one or two words would be enough to do. It also means using familiar words. Familiar words would be to say use rather than utilize, just as an example. And once again, to avoid ambiguity. And one of the most common misuses in medical writing is to use verbs. Everybody know what a verb is? To use verbs that have different strengths. And I'll explain what that means in a few minutes. Another way to avoid ambiguity is to avoid the passive voice. I'm sure in Russian, as in English, I'm sure in Russian you have the active voice. I do. I am standing. I talk to you. I know when I say I, the first person, it means I know who is saying it. If I use the passive voice and say, it was said that, who, we don't know. So the who becomes ambiguous. Okay? So the active voice is not ambiguous. The passive voice is. Now, the medical writing a couple of years ago, let's say 10, 15 years ago, many journals did not want people to use the active voice. They didn't want the first person, I or we. Some journals, for instance, the British Journal of Surgery, recently has changed its policy, but for many, many years, they would correct a sentence where you use the active voice. They always wanted the passive voice. But this is not correct. I am a firm believer, and my lesson that I give to you today is to try to avoid the passive voice, use the active voice, even if it means using the first person. Let's now go to the third pillar, precision. Precision is probably the easiest to understand because it just means using numbers, facts. No paraphrasing. For instance, the word some. Is it 1, 2, 5, 10, a few? What does it correspond to? Most? Is most 50%? 80%? We don't know. It's ambiguous. So rather than saying a few, say 3 or 4. Rather than saying most, say 60%. Something that is rare, give the percentage, 5%. Equally important, avoid adverbs like very, extremely. Very, we use the word very in our language, our common language. This is very important. But what's the difference between very important and important? No one knows, really, when you think about it. So that's why in medical writing, avoid these adverbs. Don't use these adverbs. Here's an example. Most patients. There's two problems with the word most. First of all, as I just said, does it correspond to 50%, 60%, 80%? We don't know. But it's not 100%. And because it's not 100%, when you use most, not only is it ambiguous as concerns the number, 50 or 60 or 70%, but what about the others? What about the 30% or the 40% that are missing? Okay, am I making my point? This is why you have to avoid these words because of not only they are not precise, but they leave you with the question of what's going on for the others. Precision means numbers, percentages. Percentages, I have a little bit of a parenthesis open. Don't use parentheses in numbers. Don't use percentages in numbers if the denominator is less than 50. But it's numbers rather than better than percentages only when the denominator is less than 50. I'll give you some examples later on. So these are the three pillars. I also said that the verb is very important. I'm going to take some time now, a few slides, to go through the essential points of how important the verb is. Everybody knows what a verb is. You have in a sentence, you have a subject, a verb, and then an object, which can be a direct object or an indirect object, as far as grammar is concerned, right? In Russian, it's the same thing. Now, verbs are probably the most important part of a sentence in medical writing because they are often used to indicate durations. We have also durations in whatever discipline we are in. If it's surgery, it's the duration of the operation, for instance. In chemotherapy, it's the duration of the chemotherapy. How many weeks, how many months? Or survival. We always talk about time in survival. We always talk about time in when the patient comes in and presents. How long have the symptoms been, or the signs been around? Time is very important. Verbs also set the pace. In other words, we want to know how quickly something is happening. Whether it's an operation, whether it's a recurrence for cancer, for instance, or whether it's an aggravation of pain or a symptom. But verbs are mainly used for two functions that I'm going to talk about now. The first is description. Verbs are used to describe. We have the example of a house mouse or a wood mouse or whatever kind of mouse. We use a description for that, and the verbs help us to do that. But they also are used to analyze. I'm sorry, I said two, but there's three things we're going to look at now. Describe, analyze. We'll talk about that as well. But very important and very different from description is to declare. Now I'm going to make a very important distinction between description and declaration. Because what we want to know is the strength of whether there's a simple association or something which is called causality. I have to ask the question, does somebody know the word causality in Russian? Cause and effect. Is
Yeah,
this
we
something?
do. We have причинно-следственность,
Yes?
a very similar term in Russian. Yeah.
Okay, good. In medical writing, in scientific language, causality has a very specific meaning. In other words, it says that when I cut the skin and it bleeds, there's a causality between the fact that I cut the skin and that the patient bleeds. I have no doubt, I have no second thoughts that the bleeding comes from something else. I know it comes from the knife. This is causality. However, if I look at, let's say, cancer of the skin and the fact that the person likes to go to the beach and get a suntan, I can make a supposition. I can assume that it might be related, but it's only an association. I cannot prove it. I cannot indicate any causality. It's probable, but it's not 100% sure. And this is something that we have to be very conscious of when we use the verb, to make sure that we use descriptive or analytic verbs for describing or analyzing, but very carefully use words that are used to declare for causality only when that causality is without any question. And going back to science, going back to the basics of why we should use declarative verbs only for causality, it means that we look at the level of evidence and how that evidence was found. And the only way that we can talk about causality is when we have had a randomized controlled trial that has shown without any doubt that there is a relationship between what we did and what we found. I hope this message comes through. I'll talk about it again. All these preliminaries are found once again when we look at the types of studies. A case report or a case series, sometimes also cross-sectional surveys or correlation studies, they are descriptive only. There's no comparison. There's only one case or one series or one survey. No comparison. It's just describing. If we go a little bit further and we want to analyze, is there a difference between two groups? Now we have to do something else. We have to analyze. We have to use the verb, an analytic verb, but we have to look at how we analyze. And there's two sorts of analysis, depending on what type of study we're looking at. In observational studies, in other words, we observe and we see, we don't intervene. Like a case control study, a cohort study, or we intervene, which is called an experimental study. For instance, clinical trials are, there's an intervention. The person who's conducting the style intervenes, whether it's by randomization, by selection, whatever. It's very different from observational, where we didn't intervene, we just observed. An experimental study also has its particular language. There's also another distinction that has to be made when we talk about different types of studies, is what we call primary studies or secondary studies. Difference here is very easy to understand. Primary studies are, whether they're observational or experimental, they are data that we are collecting at the time we are collecting them, whatever. Whereas secondary studies are using data that comes from another study. And this is what we find when we do a systematic review, or a narrative review, or a meta-analysis. We're using data that comes from other publications. It's not our data. So the verbs that we use, the way we describe or analyze or declare are very dependent on whether it's a primary study or a secondary study. So the style that we use depends on the type of study. In observational studies, the conditions of the study are not under the control of the researcher. You have to use descriptive language, descriptive verbs only. However, in experimental or interventional studies, where the conditions of the study are under the control of the researcher, whether it's by randomization or whatever selection process you use. There we can use a descriptive language or analytic if we do an analysis. But also, if it's a randomized control trial and we have causality, we can use the declaratory verb, a strong verb. Another very important aspect of verbs is the tense. The tense, as I said before, verb tells the time. It indicates when the action has taken place or is taking place. And especially in medical writing, we have a very particular aspect, characteristic that appears because we, as a writer, I'm writing now something that happened before. I'm describing or analyzing something that already took place. Or I'm relating a fact that is well known to everybody. Even if it was described in the past, it is still something we know about today, in the present. So you see the aspect of timing. So let's look at that. We use in medical writing, we don't use all the tenses that we have in our grammar book. We use essentially 2 tenses, and sometimes a third. Rarely a third, but let's say essentially 2 actions, 2 timings. One is the present tense, which everybody knows. The present tense indicates that the action is occurring at the time. Let's say I am speaking. You hear my words. But it also means that the fact is universally admitted, it's a truth, something that has already been proven. There you can use the present tense. For instance, cancer is known to provoke blindness. I'm just making up a word. Use the present tense. It's a current truth. I find, we find, or is found, active voice, passive voice, but present tense. Universally admitted facts. The literature shows. Is technically demanding. Can be performed. The present tense is also used when we cite figures or tables in the text. The board positions are shown in figure 2. However, the sentence afterwards, 5 chokars were used, past tense, because it happened in the past. So everything is reflected. The timing of the action is in relation to your reporting, your writing. The other tense that is widely used is the past tense, the simple past tense, which indicates that an action has already occurred before the present moment, before the moment that we are looking at as we write, and that action is finished. It's over. Using the same word find, the past tense would be found, or were found, active voice, passive voice. So we've gone from the present to something that has happened in the past, before the writing. Okay, these are the essential tenses that we use. There are also, from time to time, we use what we call the present perfect or the past perfect. Now, the present perfect is something that has already taken an action that has already been done in the past, but the results are still relevant. It's still going on. Very rarely used, but sometimes it has its importance. Has or have found in the active voice, has or have been found in the passive voice. The past perfect is also used, very rarely, but sometimes, to indicate that an action has taken place in the past, but it's all over in the past. Sorry. We use the verb had, for instance. Let me talk a little bit now about the active voice and the passive voice. I've already said, but I will repeat, that the active voice tells the reader who is doing what. We know who has said that A is better than B. We know who says that cancer can arise from smoking. But the active voice uses the first person. We. Different is the passive voice, where we do not know who undertook the study or who obtained the ethical approval or who calculated the p-values or analyzed the data. There's a description of what goes on, but we are not sure who is responsible. The subject has changed. The active voice, we know who is the doer of the action. We know the subject is always the doer. The active voice makes sentences shorter. It also indicates the subject in a strong position. We know who is responsible for the action. It's straightforward. The passive voice is all the contrary. You may want to use the passive voice if you don't know or you're not sure, but still, as much as possible, prefer active verbs over passive verbs. The problem is that we have to use the first person. As I said, most of the journals today admit the first person. Something else in medical writing that's important as far as medical style is concerned is to avoid what we call emotional terms. Unfortunately, the patient died. Of course, it's unfortunate. Or fortunately, we're able to save his life. These are common words that we use when we talk or when we speak, but they have no meaning whatsoever as far as medical writing is concerned, regrettably, hopefully. Okay, now we've looked at the style. I want to look now at the structure. Is everybody following okay? Any questions or If you want to intervene, of course, don't hesitate to.
Good for now. Thanks.
Yes? Is there anybody who wants to open a discussion or ask any questions about the style? No?
We will monitor the questions online, yeah, and send them to chat, yeah.
Okay, so should I continue?
Yeah, I think we may go on, yeah.
Okay. We've looked at the style. I'm going to talk about the structure. The structure of a scientific paper, everybody knows more or less what it is. There's a title, there's a summary, sometimes called an abstract. Two words are interchangeable. And then we have what we call the IMRAD structure, which is introduction, I for introduction, M for material and methods, R for results, A for and D for discussion. To that we add a list of references, sometimes tables, sometimes figures. But once again, at the glass bowl, we're looking at the glass structure that holds the water for the goldfish. Structure is very important because it ensures that we have an order. You saw that the introduction comes before material and methods. Afterwards, we have results. Afterwards, we have the discussion. We have an order when we compose rather than write, or when we read. It also ensures that there's a balance between the chapters that we've just talked about. It makes sure that everything is included. We know we have to have some results. We know we have to have some methods. And it guides the reader through the text like a map. They know where they have come from, where they want to go, or where they're headed. They know where to look for something very particular when they want to find a specific detail. They know how to look. They know that they have to look in the results, for instance. Let's talk about the title. Title is very important, and so important that, let me say that it is the last thing you want to compose. You have an idea of what you want to say. You more or less have the words that you need for the title, but you only compose it at the end, and I'll explain why. Because the title has to be explicit, accurate, but also enticing. We have to attract people, like the church Notre Dame or a Psychoactive family in Barcelona. We look at the church and we want to go inside because it's attractive. Title is the same thing, but it has to be short as possible. First of all, for a simple reason that Google is not able to find more than 6 words in a title. So if you have something important in your title that's the 7th word of your title, Google is not going to be able to pick it up, and then you're not going to be able to find it when you want to do your research. This means that the strong or the keywords have to be in the beginning of the title. The title says it all. The title. First 2 words. It's called focus first. The title also should reflect the main findings or even the conclusion of your paper. But it has to be clear, it has to be neutral. It always has to be objective, never subjective. Let's take an example. of what we mean when we talk about precision versus concision in the title. If I say cancer, very short, one word, but very general, not very precise. I can say breast cancer, that's a little bit more precise. I can say breast cancer in the nullipares. I can say breast cancer in the nullipares taking oral conceptives. In the European nullipares who's taking conceptives. I can go on and on and on. But you see that the more precise I get, the longer the title. So there's a balance between the number of words, the concision, and the precision. It has to be found, it's up to you. I also have to talk about, going back to what I talked about when I talked about verbs, is the type of titles that can be either descriptive or declaratory or declarative, depending on the strength of your study. If your study is a controlled randomized trial, you can use a declarative title. If not, it has to be descriptive. Once again, the precision and concision are balanced with the strong words first. Let's take a couple of examples. Gastric perforation during endoscopic resection for gastric carcinoma, the risk of peritoneal dissemination. That's the title that I use for many explanations. But here, what I want to show is that the strong words are first. This article, as I read the title, should concentrate on gastric perforation, not on endoscopic resection, not on cancer, or the risk of peritoneal dissemination. These are the consequences of the perforation. And this is, in the title, I should understand that the authors want to talk about the risk of peritoneal dissemination arising from gastric perforation. Yes, we know how it happens, the endoscopic resection. We know that it's for gastric cancer. But the main objective of this article is going to be the perforation. I also can say it in another way. If I want to insist on the fact that it's the peritoneal dissemination or the risk of peritoneal dissemination, then I would put that first. They become my strong words. You see, I'm using the same word. There's still gastric perforation, there's endoscopic resection, there's carcinoma. Everything is indicated. But I'm insisting, I'm concentrating on the risk of peritoneal dissemination here. I can also concentrate on the fact that it's endoscopic perforation. That's the most important part of my paper. So you see, the title, we can permute the words in such a way that we emphasize what we want to say, the strong words, front focus. Can we use a verb in a title? Yes, we can. But be very careful. A verb is making a statement which is very strong. We're affirming that there is an association between cancer survival and the ratio of lymph nodes. Very strong. Even stronger. Should not, should is a recommendation. It's very strong. We should only use those titles with verbs if we are sure of what we're saying. I said this once, I'll say it again, I'd like to repeat. Titles should be composed at the end. Think of what you want to write, think of what your title should be, but your final title only when your paper is finished. Do not use any abbreviations in your title, even though they might be well-known, defined. Don't use them. Acronyms, yes, you can use an acronym. Avoid using articles. The. Get rid of them. In the title, use what we call a telegraphic style. If you use a verb, never use the past tense. Don't put a period at the end of the title, even if it's a sentence. Don't mention your affiliations. The exception being, of course, geographical indications or acronyms for a study, like the color studied in surgery. As you see indicated here, the color 2. You can ask a question. You see fairly often titles that have a question mark. It means, what about? Or, well, you want to know about something, about a topic, or there is still a problem that's unsolved. For me, what I like to see when I see a question mark is I want to know the answer. If I don't have an answer, that means it's a problem that has not been solved. But this is a way of saying it, using the question mark. It's something that's well used. But the answer, if there is an answer, should be clear and obvious. For instance, here we don't know whether screening saves lives or not. So we did a systematic review. Okay, so the question is open. Is there an answer? Probably. But we find it in the conclusion. But at least the title indicates that we're going to look at it. Sometimes even, the question is, should we use large-scale healthcare interventions without clear evidence? We give the answer. You see the answer. So we know what the answer is. This is also very commonly used in the United Kingdom, but it can be used any place. It's a good way of asking the question and saying, yes, I have the answer. Do not use wasted words. For instance, a study of, investigation of, development of. These are wasted words. Obviously, it's a study, otherwise you'd not be publishing it. An investigation, of course, you've investigated something. No need for that. Think twice about using verbs, adjectives such as new, improved, novel. These words means that you have done something new. That means there's something old. Improved means that you've made progress. Validated means that you've conducted the validation. Make sure that you use these words only for specific meanings. You're going to have to prove it. So once again, think about the title from the start, but brainstorm the words, create permutations according to the focus first, where you want to put your emphasis, and then indicate and write your title at the end. Make sure it's informative, indicative. Let's take a look now at the summary or the abstract. With the exception of editorials, clinical images, and sometimes case reports, all articles have a summary or an abstract. An abstract is like a snapshot or a postcard. There's only a little bit of space that you can do, that you can write. So it has to be concise, it has to be precise, but only in a limited amount of space or a limited amount of words. Usually, a summary goes together with the title. It's like a couple. And they should be complementary without any repetition. We should not find the same words in the title and in the summary. It's easy to say, it's not so easy to do, but I'm telling you what it should be. It also has to be coherent with the text. And that's why I say, I don't write my abstract. I don't compose my abstract. Once I've finished my paper, I'm going to copy and paste particularities of the introduction, particularities of the methods, results, and conclusions into my abstract. I'm not going to invent anything new. Once again, title and abstract are written at the end. Another problem with the abstract is the fact that it is limited in the number of words. According to the instructions for authors, you may have a 300-word limit, a 150-word limit, or a 75-word limit. 300 words is not a problem. 75 words is a problem. It may take you as long to write your abstract as your paper, if it has to be 75 words and very concise. It's not easy, but it can be done, of course. Most journals will ask for a word count. There are several types of abstracts or abstracts or summaries. Usually, today, we have what we call structured abstracts. In other words, like I'm going to talk about in the paper, IMRAD, there's an introduction or a background, the methods, population, the main result. In the abstract, there's no discussion, it's just a conclusion. But we also have what we call narrative abstracts, where there's no titles, there's no chapter headings. And more today, we have visual, I'll show you an example, or video abstracts. Here's an example of a visual abstract that actually resembles something like a poster. We see the summary of the key question, usually something to do with the title, a summary of the outcomes, in other words, the decreased need for blood transfusion, so with numbers, precision, shorter hospital stay, we know it goes from 9.7 to 7. Recovery of hemoglobin post-discharge from plus 0.9 to plus 1.9, the change over 4 weeks. We know who the author is, who created the abstract. This is the visual abstract. But whatever, we have to have the study design either in the title or in the abstract. We have to find whether it's a randomized trial, whether it's a controlled trial, whether it's a comparative trial, cohort study. Somewhere we have to find what type of study. No figures, no tables, no references, no affiliations. The indication of where you're from, the hospital you work in, the city that you work in, is indicated elsewhere. No need to put it in the title or in the abstract. Once again, title and summary at the very end. Don't waste time writing your abstract. Write your paper. The abstract will come by itself at the end. Okay? Now let's look at what we call the IMRAD. The IMRAD is composed of an introduction, material methods, results, and discussion. To which we add keywords, references, and figures. We'll look at that. The introduction is like a bridge. Connects the writer to the reader. There's a gap, the water here, that is crossed by the bridge. And we want to fill in what separates the writer from the reader. We want to know what that gap is, what the average reader should know, or what the author thinks he should know, and what he's going to show in the paper. It's going to help cross that bridge. It's going to cover the gap. The length of the introduction depends on the degree of specialization. If you have a very precise topic, your introduction is very short. Highly specialized cancer units. The technique to talk about a very specific topic. It can be a little bit longer, or it can be even longer again. Everybody still hear me? I have a message that my internet connection is unstable. Can you still hear me?
Yes, I hear you.
Everything okay?
Yes, it's all okay.
Okay. So let's go forward now with the introduction. At the end of the introduction, the very end, the last paragraph, the last sentence, let's say the last paragraph, you want to state your goal. You want to ask the question or raise the hypothesis that you're going to study in your paper. For instance, the example that I gave you here, our goal was to determine whether surgical approaches to suprahepatic veins are necessary. This is the last part of your introduction. So the first part is what is known or what is not known, and what the author is going to try to show to the reader. And then at the end, the goal. Here's an example. The primary aim of our current study was to, and so forth and so forth. The null hypothesis was to show or whatever. This is the last part of your introduction. In order to help, I use very often what is called the Pequot or the Pequots Framework. Pequots stands for population, intervention, comparative, outcomes, timing, and setting. For instance, we hypothesize that patients with peritonitis, that's the population, from complicated diverticulitis, receiving, that would be the setting, receiving antibiotics, that's the intervention, for 3 days, that's the timing. We'll have fewer surgical site infections, that's the outcome, than patients receiving antibiotic prophylaxis only, the comparator, or the comparison. So you see the Pequot framework is a very useful way of making sure that you have an introduction, or that last sentence of your introduction is there. I'd like to insist on the fact that this sentence is probably one of the most important parts of your paper. It should be the guide to the whole rest of the paper. The methods, the results, and the discussion all have to have a relationship to that last sentence. Your conclusion has to have a relationship to that last sentence. Your title has to have a relationship to that last sentence. This is something that's very often ignored. If you can compose that last sentence of your introduction, you have given yourself tools to write a good title, good abstract, good conclusion, and a good discussion. Let's take a look now at material and methods. Material and methods is a chapter that's very straightforward. You have a population, you describe it. You have an intervention. Maintained all throughout the paper. How you did what you did, the methodology, the technique, sometimes why you did it that way, if it's pertinent to the methods, if not, you use it in a discussion. How your data were analyzed, what tests for statistics that you used, what methodological instruments you used to analyze your data, and also ethical issues indicating whether there was a IRB approval. IRB means Institutional Review Board approval, or a committee that looks at the permission that you need to use patient data. In a clinical trial, a randomized trial, there's also another ethical issue, which is called the Data and Safety Monitoring Board, DSMB, Data Safety Monitoring Board, which looks at make sure that there is no adverse events that occur that could put the patient into any danger. Material methods is very short. Only material methods, no intervention, no interpretations, no comments, no discussion, just objective facts. You can balance that somewhat with the tables and figures, but you have to avoid duplication between the two. No, I'm not going to show this example. We don't have enough time. Very often, we use what we call the consort flow diagram. Now, this consort flow chart or flow diagram was designed initially for randomized controlled trials, but today we use it for all comparisons. Whether it's randomization or whatever selection method you've used to allocate patients into two groups, we have to know how many were eligible, whether the enrollment was full for everybody or whether there was exclusions or not inclusions. The selection process, whether it's randomization or whatever I said, the two groups that we want to compare, how they were selected, allocation, how they were followed up, and how they were analyzed. And at each time point, how many actually received what they were supposed to receive, how many were lost to follow up, why they were lost to follow up, how many were available for analysis, and those that were not analyzed. So this consort flow chart is something we use every time we have at least two groups in our description. Here's an example. And this is very often the first figure that we use to accompany our description. Once again, the enrollment, the allocation, the follow-up, and the analysis. Very important, increasingly so, are definitions. If you have a definition, if you're using a term or a terminology that has several meanings, make sure you define exactly what you mean by overall survival, for instance, or cause-specific survival. These are these have been defined. And if you use another definition, you have to say that you modify the definition. We have to know, remember, I said that a medical article has to be reproducible. I have to be able well, as a reader, when I see overall survival, I want to make sure that the writer is using the same term for overall survival that I would use if I were looking at my patients. Therefore, the definition has to be someplace. I have to find it. I have to be able to be sure that we're talking about the same thing. Results. Results are nothing else. Your results, the results of that study that you're doing, that you're writing about, not from something else, not from anybody else's study. Only include the results that are relative to the questions that you have asked in the introduction. Once again, the importance of that last sentence of the introduction, whether they support the hypothesis or not. No interpretations, no comments, no emotional, only 2 complications, no. Very strict, objective terms, no discussion. Like in material methods, only facts. Results, we have another possibility, and I'll talk about that in a little while, is the figures and the graphs. Use them as much as possible. Avoid the words. Tables and figures speak much better than words. But avoid repetition. It may be better to talk about the gender or the sex in the text and not repeat it in the table. Or it may be better to put it into a table. We'll see some examples later on. It's up to you to determine which format is best to transmit the information that you want to send out to the reader. But don't repeat it. And always be aware that maybe you put it in the text and the editor will ask you to put it into a table or to a figure. It's not a big problem. Very important, however, is once you have defined your population, whether you're talking about them in the material methods, in the results, or in the discussion, make sure we know, or the reader knows, that you account for 100% of your population. Don't explain what was happened to most of the patients or the 70% of the patients without telling what happened to the other 30%. There's no room for guessing in a scientific article. We have to know what happened. We have a whole population. We have to know what happened to that whole population, all throughout the paper. Missing data, it happens. Say so. That we know that, for instance, you had 100 patients, but for the hemoglobin level, you only had information for 98. If you calculate an average or mean for that, we have to know that the denominator is 98. It has to be indicated. It has to be sure. We have to be sure that we're talking about 100% of the patients, or otherwise, we define why we are not talking about 100% of the patients. No room for guessing. We have to know what's going on. A question that's often asked is, where do you put the number of subjects, for instance, the population of 100 patients? If it's a retrospective study, it's probably best to put it into methods. If it's a prospective study, that means there was an intervention that determined that there was 100 patients. It may be better to put it in the results. A randomization, obviously, it would be in results. But for an ordinary prospective study that's not a randomized trial, you can choose the methods or results. Doesn't make a big difference. Let's look at the discussion now. The first sentence of the discussion, the first paragraph of the discussion, is relative to the last sentence of the introduction. The last sentence of the introduction, you raise a hypothesis, you ask the question, you give the answer here. The first paragraph of a discussion is not a review of the literature. It's the answer to the question that you asked at the end of the introduction. Here, they repeat what they did, but then they said that the answer is we hypothesized that the administration of fixed duration antibiotic therapy 4 days after source control would lead to equivalent outcomes in shorter duration of therapy as compared to traditional therapy. Everything is there. The Pequot, population, intervention, comparator, outcome, and timing is all answered here. The rest of the discussion, after the first sentence, has something else, has another function. Once you've put the main results here, without repetition of methods or of actually results other than the comparison that you're talking about, for instance, here, you want to now explain how your results support what you've just said. How the data or the answers that fit, that you have found, fit into the existing knowledge on the topic. Remember in the introduction we said what is known, what is not known, and the gap that we want to fill. Now we're going to talk about that gap. We're going to talk about that information, whether it's known or not known, and compare what we have found to what is known or what is not known. That's what the discussion is about. It's not a review of the literature. It's not repetition of results other than saying how those results support your hypothesis or fit into the existing world of knowledge on that topic. So you're going to compare your results with the literature. You're going to say your results or investigations are similar to what other people have found, or they're different, but you're going to explain why. You found that A is better than B in your population of 150 male patients. Mr. So-and-so may have found that A is better than B, but only in females, only in Hispanics, only in Asiatics, whatever. You want to compare what you have found, what you looked for, what you found, and see why your results are similar or different from what has happened in the literature, what has been reported in the literature. But it may be that you found something that was not looked for by the others, that you can point it out and saying that that's one of my strengths, but you have to explain why. Or, and don't forget this, be very, very honest, what others have found that you didn't find because you didn't look for them. This is one of your weaknesses. And explain why. So this is what the discussion is about. And this is why, if you don't have this mindset of how to write a discussion, you're going to get it wrong. You want to comment on the strengths and the weaknesses of your paper, why you preferred this method and not another method. There may be other methods to do something. Why did you do that? And that's in the discussion that you did that. How you dealt with missing data. How you dealt with patients that were lost to follow-up. What are the shortcomings of your paper? It was not a controlled randomized trial. or it was a controlled trial, but it was not randomized, or it was not a comparative study, or it was not a complete review of the literature, whatever. You have to state in the discussion what your weaknesses are as much as your strengths. There's a strength, there's the weaknesses, indicated in the discussion. Limitations. The last part of a discussion, sometimes headed off in a chapter by itself, is the conclusion. But your conclusion should be very specific, only on the population, your population, the population that you described. Not about another study, not about somebody else's study, not about what you think a generalization should be. Only on what you have described and the population that you have included in your study. No generalities. You're not there to make a lesson. You're not there to show that because you found that A is better than B, that you have found that A is better, that you should be using A is better than B. That's not the point. Based on our results. How do your results what we call external validity? Can what I have found in my study here in Paris or in Moscow, can I apply it if I'm a reader in Shanghai or in Pakistan or in the United States? Where do we go from here? Is it useful? A is better than B, but B may have more side effects, less side effects, I'm sorry. A is better, more effective, but it gives side effects. For instance, the current discussion today with the COVID of whether we should be using drugs, anti-malaria drugs, that everybody's talking about. They may work, but are they useful? How can we implement them? Make sure that there's no side effects. Also, how the shortcomings of your study was not a randomized controlled study, so maybe you have to do a randomized study. Maybe your shortcomings is that you only use the population of 100 patients and you should be using perhaps 200 patients. Perhaps also that you studied only males. You should be including maybe males and females and so forth. How these shortcomings can be improved in the future. And what are the implications? A is better than B, but is it something you can use every day? Should we use it? Why should we use it? All these, and this information belongs in the conclusion. Whatever you do, don't be tempted to write a comprehensive review. That's good for textbooks. It's not for a scientific writing. And avoid what we call elitism or triumphalism. Don't say, we are the best. We are the only. No. This is not scientific writing. Don't be overcritical. Don't cite only what goes in the. Don't hide anything. Don't be tempted to write a comprehensive review. I've said that before. Beware of repetition with your introduction. Provide shortcomings and so forth. Where do we go from here? Where's the future goal? Where are the future research? How can we use our methods to go further? or results? Or are there other goals to be accomplished? Or is there something else that we have to do? These are what a conclusion should be. Do not use conclusions that are inconsistent or misleading or misinterpretable because you want to push a message that has nothing to do with the study that you have just done, or it is the message that you would have liked your study to be able to conclude. Very often people do that. This is not good medical writing and it should not be permitted. Make sure it's pertinent, make sure it's adapted. Make sure that it's study related. My last slide, how do we compose, how do we do this? What we've just said. I usually make a rough draft of my tables, my figures. Then I look up my references. Then I start to write my aim at the end of my introduction, 1 or 2 sentences. Then I follow up on the methods and results. Then I write my discussion. But then, only then, do I finish the rest of my introduction to make sure that I'm really citing what is known, not known, where I'm going, where the goal is. I finalize the tables and figures to make sure that the information is correct and it corresponds to what I put into the text. And then, and only then, title and abstract. Okay, so I finished the first part of my talk. I probably didn't realize that I went over time, but that's okay. Is there any possibility of having any questions? If you, I don't know how you want to conduct this, Dimitri. Hello? Anybody?
Yep, I'm here. I was on mute. So if you see the chat screen, you see some comments there, and we're monitoring.
Yeah. Here on the bottom here.
More.
Here.
On the chat button below the screen.
On the bottom of the screen.
On the bottom of the screen. Yeah.
Yeah. Okay. I see that there's a possibility of like a blog. Is that it? But nothing. It's not active.
So the comments from the users. As for me, the passive voice and emotional words make a manuscript more comfortable and interesting to read. So what do you think about it?
I see now. Okay, for the passive voice and emotions make the if you're more comfortable with the passive voice, well, certainly emotional words, no. I do not agree. And if the person has found that on a YouTube, please send me that YouTube. Please send it to me so that I can write to the sky and say that I do not agree. I would certainly not agree with that. I talked to you about the passive voice. It's very difficult sometimes to use the active voice all the time. It's not a mistake. But you have to realize that it's more impersonal, less direct, less precise. That's it. Okay.
I think it's part of the Russian mentality. So we have a kind of a bigger distance than social distance than most of the Europe and United States, and this is why usually you hear more of kind of passive voice and.
As I say, it's not a mistake. It's not a mistake, but you just have to realize that it's less direct. And I think we'll get away from that even in, it was the culture also in Europe or in the United States many years ago. But this has to evolve. I think it has to evolve. But emotional, no. No, there's no emotion, no place for emotions in medical writing.
Okay, thanks. And another question is, what do you think about papers called like "How do I do it" versus "How do we do it"?
Yeah. Okay. I mean, if that's technical advice of how we do it and how, yeah, sure. These are things that are fairly easy to write, and but you have to write the paper correctly, and you have to find a journal that's going to accept it. Of course, not all the journals want papers like that.
So this is not emotional, right? This is
Oh, no. This is not what I call it. Emotional means emotional words, okay? Fortunately, 75% of the patients did not die. We don't need the word fortunately. We just say 75% of the patients or 25% patients died. We use the facts. We don't use emotional words to sort of justify that only 25% of the patients died or something like that. That's what I meant by emotional.
okay, clear. Let me check if there are any other questions.
Okay, I'm sorry, I don't know how to go back. I just want to I didn't print out the program. We were, what time is it now in Moscow?
It's 11:40.
Sorry?
20 minutes to 12. So 11:40.
12. Okay, so we have about an hour and a half left. Is that right?
Yeah, correct.
Okay. Is Raman around? Is Raman one of the listeners?
I think he's online, but not in the Zoom currently.
Can I hear his voice?
If he comes to Zoom, then yes.
Ah, okay.
So he's online on the portal on MEDX, but not in Zoom.
Ah, okay, because it's difficult to. Well, what I can do is I'm going to put his paper on. Can I put his paper on the screen?
Yeah, sure. Just by sharing the screen.
Can you put it on, or should I put it on?
If you don't mind, just put it on, because otherwise you will have to send it to me.
Ah, okay. Let me just give me 2 seconds to find it again.
And we have one more question from Konstantin Loban. Should we use passive voice with passive with definitions? Patients underwent operations in our clinic, or when we defined once that this is patients operated in our clinic, should we use passive for these patients in the text below?
I'm sorry, I don't really understand. Say it again.
So should we use passives with definitions? For example, we've defined once that the patients underwent, we mean the patients that underwent operations in our clinic. Should we further on still use the passive voice saying, patients operated in our clinic, or we just say patients, or we do it some other way?
Well, I'm not sure I understand, but I think I understand what you're trying to about. If you talk about, once you define your population, you can always use that same population. You can use the active voice. But if it's in one, yeah, okay, I understand it. Once you define your population, you want to use the active voice, it's much better. But if you want to use the passive voice, you can, because you've already defined your population, so we know what you're talking about. So there's no conflict there. Is that the answer?
Yeah, I think fine.
Okay. Okay, I put the paper on the screen. Can you see it?
No, you need to share. You press the share screen button below.
Okay, I have to go back to
Zoom. Yeah, and press share screen.
Yeah,
and choose the window with the paper.
Sorry. Here, maybe? No. Oh. I did something wrong, I'm sorry. Here it is, Zoom, okay. And now I go share the screen. And then here we go. I found it. Okay, now you can see it.
Yes. Yeah, cool. Thank you.
All right. We don't have much time to go through everything, but I just want to point out something, for instance, in the abstract here. We said that the abstract is a snapshot, so it gives us an idea of what we want to do. We want to talk about, in this paper, the authors wanted to talk about the simultaneous use of laparoscopy, simultaneously conducting a distal gastrectomy in a patient who had liver cirrhosis. Liver cirrhosis, of course, with the difficulties that everybody knows when they operate on a patient. And the possibility of portal hypertension being also something that's going to influence the prognosis. So if they did a staged operation, in other words, the gastric carcinoma distal gastrectomy in a patient who had cirrhosis that was still under the condition of cirrhosis, they would have a very complicated, or they might have a very complicated outcome. And the portal hypertension complicates the fact that the cancer is a very difficult operation. So the idea behind this paper was to talk about doing the total laparoscopy, distal gastrectomy at the same time as a splenorenal venous shunt in a 68-year-old lady, 68-year-old lady, if I remember that. Yeah. So let's take a look at just at the introduction. The title, once again, is first gastric distal gastrectomy for the cancer, and then splenorenal venous shunt in the patient with cancer and cirrhosis. The introduction starts out with cirrhosis. No, your introduction has to start out with cancer, or distal gastrectomy being the gold standard for cancer. You should always have the same chronological order. If you want to talk about cirrhosis first in the introduction, then you have to talk about cirrhosis first in the title, which is not the main point here. Okay? So your introduction should start with, here, for instance, there's nothing about gastric distal. In the abstract, go back to the abstract, you say distal gastrectomy become the gold standard. Why don't you repeat it in the introduction of your paper? This gives the background for the gastric component. Then you talk about the liver cirrhosis. Then you talk about the fact that operating them in a staged way would be difficult, complicated, and your idea was to do it simultaneously. Okay? So actually the introduction should be a different order. But once you've done this order, I think it's really cool because it's very short. There's some grammatical errors that have to be corrected. I'll do that and send it to you, Raman. But other than that, the title, the introduction is pretty good. Material and methods. The patient. Also some grammatical errors that have to be corrected. But other than that, not so bad. Preoperative treatment. Okay. Surgical procedure. Okay. This is something that we all are, let's say, faced with, that we have to deal with in a very special way. Once we have a technique indicated for a paper that's talking about the outcome, we're looking at the outcome of a simultaneous laparoscopic procedure for cancer in a patient who has cirrhosis. The technique that we use is, we're very proud of it, of course, but that's not the essence of your paper. There's too much detail of where we put our profile, where we put our 10mm port, where we put our 12mm port. These are details that have nothing to do with the topic. Everybody does the same thing. I'm not being very mean when I say this, Robin. Performing the gastric distal gastrectomy according to Japanese guidelines, yes, that's okay. But where you put your ports, too much details, not needed. The fact that you did a Roux-en-Y reconstruction, that's enough. You don't need to say that the small bowel was divided by this and that the Roux-en was marked approximately, the staple was done this way and so forth and so on. These are details that are a part of your technique that are okay. I mean, everybody knows that. And it has, it's not that you don't need them to do what you're saying or to write it, but it has no consequence on your topic. Or if it does have a consequence, then I want to make sure that I find it in discussion, but I didn't find it in the discussion. I hope I'm making my point. Then the post-operative, okay, very short, that's okay, that's good. Further treatment. Okay, this is probably too long, we don't need it. Now let's go to the discussion. First set of the discussion is what? The standard of treatment, you're talking about a general statement. No, this is not what the discussion should be. Your discussion should start with the answer to the question that you should have asked at the end of your introduction. Let's go to your end of the introduction. Where is the question? Where is the hypothesis? What do you want to show? You want to show that laparoscopy is an elegant situation for performing distal gastrectomy for cancer, the splenorenal shunt for the cirrhosis, but portal hypertension in a single intervention. And one of the main objectives and the main advantage, I'm going to go confusing for everybody, but one of the main conclusions here is one of the most important aspects is here. Can you see what I've just highlighted? Does everybody see what I just highlighted on the screen? Hello? Hello?
Yeah, we see it.
You see it, okay?
Yeah,
This
perfect.
is
Well,
the most
thanks.
important thing. This is one of the most important things. And I'd like to find that in my introduction. I don't see anything about it in the introduction. I don't see anything about it in the discussion. The discussion is all about, it's like a review of the literature. No, you want to say why gastric cancer can be treated laparoscopically, why portal hypertension can be treated with the portal shunt laparoscopically, and why it was good to do it at the same time, and why it was good to do it laparoscopically, because of the fact that the collateral circulation was not interrupted by a midline incision. Okay, I hope I make a point here. And then the conclusion. You don't assume anything. The conclusion is that simultaneous treatment can be performed at the same time. In other words, for cancer and for cirrhosis. Don't repeat the results. Say that it was possible in your case, the outcome, or something like that. Yeah, 8 days. Even though she had a relapse 6 months later, or whatever, no, 2 years later, 33 months later, she had a relapse of her cancer. It's still a good result. And it shows that minimal invasive techniques for these patients is not only, I'm sorry, yeah, you did it here. Okay. I'm sorry, I didn't see it before. And the earlier start of antiviral therapy, that's also something that's very important. Yeah, so your paper has some very strong points, very good points that has to be finalized and have to check the grammar. Your references are not according to any instructions of authors. I don't have the time to talk about it today, but I'm sure you know that the references have to be names of your authors out in the chronological. And here is something that is, if I may say so, I'm not trying to be mean to you, Raman, but when I see a reference indicated like that, I say, this guy is not serious. Why? Because you see 1 and 2, what does that mean? That means that this title was copied from somebody, from the internet. 1 and 2 is the reference to where he works, the affiliation. But that means you put it there and you didn't check it. Now, I'm not saying this to be mean, but very often when I see something like that, I say, did that person, the author of that paper, I'm sorry, did they actually read that reference? Or did they just copy their reference and copy something that was copied from that copy? You have to be very careful about what we call secondary referencing. Let me talk about secondary referencing just a few minutes. When you go to a paper and you want to cite something, cite only what is in the methods and results of that paper. Do not cite something that's in the introduction of that paper or in the discussion of that paper, because it may be somebody else that cited that already. And that's called the secondary reference. And when you do secondary referencing, there's a big problem because you have an intermediate who makes his interpretation. And the fact that you cite something that has already been cited by somebody else, you may have introduced a bias in the way that person has introduced or interpreted the first reference. So we have to avoid what we call secondary references. And when I see a reference indicated like that, I'm not so sure that the authors of the paper actually read the paper. It's just an indication. And you have to be very careful about that, because if you do not pay attention to details like that, the peer reviewer might get a false impression. I actually like this paper very much. But aside from the fact that I know Raman and I know the team in Moscow, I would be wary of the fact that if I found this reference indicated like that, it would take away from the value of the paper. So be very careful. Be very careful about details. These details can have a very serious implication on the way your paper is interpreted. Okay? Anyone want to make a comment on this paper? I know I went through it very quickly, but time will not allow us to do any better. Any comments?
Yeah, I think in general from the comments, people would agree. There's another question, by the way, from Konstantin. First of all, thank you for the explanations and answers on the previous ones. But about the abbreviations. So if you are talking about some really long named study or paper, and you need to somehow shorten it so it's readable for the readers, for the audience, you can still convey meaning. Still possible to use abbreviations, or better to try to reformulate the name of the paper? Thanks.
Well, once you've defined an abbreviation, you can use the abbreviation. There's no problem. You don't have to redefine them anymore. No.
But the issue is that I think you cannot define the abbreviation in the name of the paper, right? So if it's a title, then obviously abbreviations won't help, right?
So you have to redefine it in the text, not in the title. And once you define it in the text, it's not if you use it in the figures, if you use it for something else, you have to make sure that you don't use it, that you have to redefine it every time you use it. Something very important. I did not talk about that. If you use an abbreviation, you define the abbreviation in the text, but you use that same abbreviation in the figures or in the tables, that abbreviation has to be redefined in the tables and in the figures. Okay.
Okay, clear. So for the title, it's actually not very much recommended to use the abbreviations.
No abbreviations in the only acronyms. Only acronyms can be used in the title. No abbreviations.
Okay, I think that we might be, we might be missing the difference between the acronyms and abbreviations. So abbreviations are something shortened words, not the acronyms, which are the letter. Yeah. Okay. So I understand now the point. I think that it's important for the audience to also get the difference. But thanks.
Okay. Now I have to go back to another slide, so please help me. Can you see my screen?
Yep, I need to stop your sharing, and you will restart sharing from the presentation. Cool.
All right, but I have to. Okay, maybe it's here. No. So maybe I should wait a minute.
You will need to come back to Zoom to
open my
start
slides.
sharing the screen. Press the share screen button and then choose the slides. Yes.
Okay. Let's see. Okay. Here.
So actually, as part of sharing something back, the idea is quite simple. If you would like to share different applications, then you just share the screen and switch between them. If you only share one application, for example, a presentation, then you share one application to avoid showing everything else.
Let me put mine up so I can find it, and then you can tell me what I should do. But I can't. I don't understand why my screen is not active. Okay, I see. I understand. So I have to go here. Okay. Okay, I have my presentation is on the screen.
And you now need to start sharing again from Zoom, the green button.
So I have to go back to Zoom. Yeah, but this thing is blocking it. Okay. Yeah, share the screen. Okay. You still with me?
Yeah, we're with you. We see you perfectly well. But
Okay.
you
Okay.
need to choose what to share.
But I can't. I don't know.
So in Zoom, you press the green button and then you choose the screen. You choose what to share because it.
There's nothing. It says Microsoft OneDrive, Google Drive, or Box.
Oh no. Let's go again into the Zoom window
I found it.
and press the green. Okay, yeah, cool.
Okay, there we go.
Thank you very much.
Okay, now I have to put this into a. No, here we go. Okay.
Okay.
Can you see visual aids?
We do see the next slide and the slide lineup. So this is also fine, I think.
Can you see now visual aids?
Yeah, we see the slide. Yeah, visual aids.
Okay. Oh, but you see the next slide as well.
We see the next slide as well because you turned on the presenter view. So
Okay.
we see the presenter view. Unfortunately, because it's one screen. Yeah.
And do it this way.
Yeah, just like this.
Okay. Is that better?
Thank you. Perfect. Yeah,
Okay.
absolutely.
Okay, so now I'm going to talk about visual aids. Well, we have about an hour left.
Yeah, exactly.
Okay, I'm going to try to finish and perhaps take a look at another one of the other papers that I have. There's two other papers that were submitted, one by on the cytological diagnosis of detecting free cancer cells, and the other one paper that I already corrected, I think, on the laparoscopic versus open fry procedure. If the authors of these two papers around, are they participating also in this conference? The author of the cytological diagnosis is Putova. Is that person around?
I will need to ask Anastasia if yeah,
they're listening. Is that it?
I think they are, but we don't see them in Zoom.
We can't communicate with them. Okay. Okay. All right. Okay. Well, let's go on with the slides. So I'm going to talk about figures and tables and figures now. These are visual aids that are very important to include in your presentation. But you have to remember that they are complementary to the text. And so they have to be used very carefully, selectively, and they have to be very instructive, very indicative. Visual aids are a way of summarizing information, simplifying it, improving the conciseness. And if they are done correctly, they aid considerably the presentation, the comprehension, and the visibility of your paper, the visual appeal, so to say. more importantly, some people, when they want to look at a paper and read it and analyze it, the first thing they do is they look at the tables and they look at the figures. And this is going to be something that's going to indicate to them whether it's appropriate, whether it's interesting, whether it's worthwhile reading. So this is a visual aspect that's going to indicate from the start whether the paper is interesting or not. Tables and figures are what we put in oral presentations when we make our slides. It's always the same information. And each visual aid, whether a table or a figure, is a part of the written story. But it has to stand out on its own. We have to look at a figure, we have to be able to look at a figure or to look at a table and understand it by itself. We have to be able to understand what's going on in the table without going to the text and so forth. They have to be independent units of information. And actually, there should be a balance between the text and the visual aids. Some of the general principles behind tables and figures are in common between tables and figures. Each table or each figure should be a complete unit of information. In other words, we need a title, we need an explanation or legends if it's a figure, or an explanation of abbreviations if it's in a table. The title has to be informative. You have to understand exactly what we're talking about just from the title, and understand what the purpose is. Tables and figures should be in a logical order. And usually we talk about a chronological order. In other words, if it's a surgical issue, preoperative patient population, operative, and then postoperative. Or for chemotherapy, cancer condition, the cancer regimen, and then the outcome. The number of tables and figures is predetermined by the journal in the instructions for authors. Usually not more than 4 or 5, exceptionally a little bit more. If there's less, it's not a problem. By convention, we always write table with a capital T or figure with a capital F. We can abbreviate figure with FEG or FEG dot, but never abbreviate table. I already talked about how you cite tables. We always use the present tense, remember? Or sometimes you don't even need a verb. Either you just indicate table 1 between parentheses, as you see here, or as you see here for the figure. Or you can say in a sentence, as shown in table 3. Either way is okay. But every table and every figure has to be cited in the text. There is a one-to-one correspondence to what you write and to what you find in the tables and figures. For every table, there has to be a citation in the text. For every citation, there has to be a table or a figure aside. Very often, very often, from time to time, for instance, when I correct a paper, they say, indicated, this information is indicated in table 3, and there's no table 3. No, this is sloppy. This has to be very correctly performed, very correctly and very diligently. We have to be able to ensure we have this one-to-one correspondence. If you cite more than just table 1 or table 2, table 3, and you want to indicate what it's about, don't cite the title, but create a phrase, a original phrase about the information that you find in the table or in the figure. Don't repeat the title of the figure in the text. Tables and figures are ordered in chronological order, as I said. We ordered them with Arabic numbers, no Roman numerals. In the past, journals required that figures be in Arabic numbers and tables with Roman numerals. No, this is no longer the case. We always use only Arabic numbers today. All numbers, all tables, all figures have to be numbered independently and in a chronological order. Even if there is only one table or one figure, it's called figure 1. This should not be, as you see in the example that I gave you here, just one figure. There has to be a correspondence between the numbers. Now we come to something very important, and that is, what are the ideal dimensions of a table? And that leads me to a discussion that's going to be difficult to show on Zoom, but I hope I can explain it. Usually when I'm in front of people, I can explain it much easier. I'm sure you all know the difference between what we call portrait and landscape. Portrait is when the image is higher, is longer than the width. Landscape is when it's wider than high. Okay? When we read a journal, as you see there, surgical endoscopy, we see it's in a portrait format. But a computer screen, that you're all looking at, is in a landscape format. Now, when you're doing a table and you want to publish it in a journal, a paper journal, which is okay. Nowadays it's disappearing, but still, we still have paper. You want to make sure that it's readable. For a journal, it's not a problem. You can take your journal, you can turn it around. If a table were in landscape in a portrait format, just turn the journal around and you can read it. But on the screen, you can't. Your computer is fixed. Even a portable, you have to. If you had something like that, upside down like that, you cannot read it. It's in a portrait format on the screen, but it was originated in a landscape format. You can't read it. If you're an owl, maybe you can read it. Otherwise, you can't read it. Or you need to have 24 cervical vertebrae. So be very careful. Decide what format you need and make sure that you abide to the instructions for authors and make sure that it corresponds to the information that you want to portray. Sometimes now, in the electronic system, one page can be in the portrait and then the next page can be in the landscape format. But not all the journals online do that. When you create your tables, make sure that you create it with a tool that is compatible. Now, for the reasons that I just don't understand, and it's been around for years and years and years, there are spreadsheets like Excel, which are used very often for accumulating data. But the electronic publishing system does not allow Excel to be used to go into the text. I don't know why. It's an informatic problem, but I don't know. And no one has thought about how to resolve the problem. So create your tables with the table tool in Word. Use the same format. If you're writing with Word, you don't write with Excel. So you write with Word and then create your table with Word. It will be compatible. If you use Excel inserted into Word, it is incompatible. It doesn't work. Make sure that your tables are editable. In other words, that you can change the information in each cell. Every little box is called a cell. Don't insert images. Make sure that it's editable. Make sure that you use headings and subheadings in separate rows and separate columns if necessary and as necessary. Make sure that they are set off specifically and don't try to recompose. I'll talk about that in a few minutes. Make sure that all your tables and all of your figures are no larger or longer than one printed page. If it's not possible to get all the information that you want into one page, then you'll have to find some other way to put it on, publish it on online information or something like that, an additional additive. But don't include a table of more than one page in your paper. It just makes things too difficult to understand. I'll show you an example. So let's go back to the cell problem. Here you see we have in the first column and the first row, 2. First column, second row, 4. And then we have 34 patients here, 67 patients here, 56 patients here, 89 patients here. It may be that only 2 and 4 patients here, they give a false impression that there's an independent group. So maybe you want to combine A and B, come up with 36. 4 and 56 equals 60, and then you only have 2 groups. Much easier to see, much easier to read. Okay. But whatever you do, keep this information, because somewhere, if your paper is not accepted, somewhere you have to be able to find this information that this 36 was composed of 2 and 34, and that this 60 was composed of 4 and 56. So use Word, combine your cells, but keep the information. Tables should be left justified and then aligned in the cell. I'll talk about that in a few minutes. Don't use the return tab. Don't merge your cells. Don't use color. Don't use different fonts. Don't use shading. A minimum of lines. And don't insert, as I said before, any boxes or pictures or tables with themselves. The legend here is at the bottom of the table. For some reason, my slide is not working out here. I'm sorry, this is not what I want to say. I want to make sure that you understand that the citation of a table or of a figure should be in a chronological order. In other words, here we have a paper where we see figure 4 indicated here, and we see figure 4 here. We don't have to look for it, it's right there. And make sure that when you write your paper that you say where you want your table or your figure indicated, and you can put that into your paper. What you want to avoid is something like this. Here we have a table 4, but we don't see the text beforehand. We don't know where it is. The table 4 is indicated here. So it's indicated after we see the table. This is not good. The citation has to be before we see the table. The caption or the title of a table is on the top. And tables are read from top down, left to right. The title is on the top. We read from left to right, from top to bottom. Graphs, the title is on the bottom, and we usually read from bottom up. Once again, from left to right. Avoid verbs, use telegraphic style. Some journals will require, but if they don't require, I think it's best to use what we call a bold font. We talked about this with the abbreviations. No abbreviations in the legends or in the titles of the paper or of the figure. Even if that legend or figure, even if that abbreviation, I'm sorry, has been defined in the text, you have to rewrite it out in full when you use it in the title. If you have explanations in your tables and your figures, you want to indicate, for instance, statistically significant differences, you can use asterisks, or you can use footnote symbols. Don't use italics in different colors, which are good for slides, but they're not good for publications. You can use superscripts or superscript numerals or the symbols. Now, I'm not so sure I have a slide on this, but let me just explain. If you have the possibility of putting using Editorial Manager or EndNote or some reference system that puts your references into a linkable fashion, in other words, when the mouse goes on it, you see that it's active, or if not, if it's just written, they should be between square brackets, not round brackets. If this is not possible, use superscript letters, especially for numerical data. The superscript numerals also avoid the problems of confusing information between parentheses with references. there is a logical order, but it depends on the instructions for authors, for tables or figures, especially for tables rather, whether you should go by column or by row. Usually, as I said, it's by column from top to bottom. First column, top to bottom, second column, top to bottom, third column, top to bottom. Some journals will indicate by footnotes if you want to have a specific order. You see the footnote symbols. But let's take a look at an example which is well done. Here we see characteristics of patients at baseline in the Portico IBE study with a star. The first footnote is therefore the star. Plus, minus values are means. Correct. First column, top to bottom. The first thing we come across is a double cross here, but the double cross is here. The single cross is indicated here, and we find that it's a p value. I'm sorry, the problem is that your pictures are covering the cross. Plus it's okay, it's in chronological order, and then you have a double cross. Okay? P-values should be in the last column, typically. If there's too much information, if there are too many tables, you can use what we call supporting information files. Look at the instructions for authors to find out if it's possible and indicate that in what we call the cover letter. If we have time, I'll go to the, oh, we don't have any time. Once again, do not use Excel or PDFs for this. These are not readable, they're not editable, so don't use them. And also be very careful. GPG is not editable, JPEG is editable. TIFFs are not editable. EPSs are not editable. I talked to you about the alignment of decimals, of units. I'm going to try to show you why it's important. Dimitri, is there any way you can take the photos off of the screen here at the end, on the right? Because it's covering the slide and I can't see what I'm trying to say. Dimitri? Hello? Can you hear me? Hello?
Да, мы здесь.
We're here. We're done print screen.
Anastasia?
Yes?
Yeah, is there any way you can take the pictures off the screen on my computer?
Yes, I took the print screen of this picture. I'm sorry, what I have to do?
Sorry?
What I have to do?
Can you take the pictures? On my screen, I have my picture, your picture, Dimitri's picture. Can you take them off my screen? Because they're blocking the slide. I can't see the slide.
You can see your slide.
I cannot see my slide, no.
Do you see?
I can't see the whole slide, if you prefer.
You can actually press. So this is this works for your screen only. So what you can do is you can so above the pictures, there are different buttons for how you see them. You can see them as thumbnail, as do you see the buttons there?
Maybe if, okay, I just said, I got it. Okay, thank you.
And you can just remove it to the side of the screen. Thank you.
Thank you. I think it's perfect. Okay, so let's go back to this slide where I'm talking about the alignment of the units or of the decimals. You can see on the left and on the right that the units are aligned. I'm sorry. The 0, the 4, the 1, the 0, all are in the units, they're all aligned. This is perfect. This is very good. On the right side, same thing. We go down 25, 24, 20, 15, 6 is under the 5. But when we come to the decimals, there's a problem. Here, the 4 is under the 10ths. This is not good. You should be able to read this as 9 should be under the 4. But once they are here, they're aligned. It's okay. We're going to see examples where this is very poor. This, for instance, is a very poor table. Misleading. If I look at cow, rural area number 2, and I read it quickly, I can mistakenly understand 91.4 and not 9. You understand? These have to be aligned. If I go to the first column, 617, 11 should be under the 17. 8 should be under the 1 of 11. 79, the same as 11. 28, same as 79. 112, the same as 617. 39, the same as 79 or 28 or 11. Okay? The units have to be aligned. If you have too much information, it's not going to work. Remember I told you, we need 1 table per page, not more. Oh, something's wrong. Oh. Yeah, and you want to make sure that the size of the letters is readable. We don't want this to be a Snellen eye chart. We want it to be a table that's understandable. Take a look at this table, which is 2 pages long. First of all, there's too much information. We don't need all this information. It's not going to be readable. It's not going to be read. People are interested perhaps in the information. If that is the case, put it into an annex. This is typical of when we do univariate analysis. We want to make sure that everyone understands that we did everything possible. We compared every single characteristic in each patient. Okay, it's enough to say that you did that and to find that information in an annex, but it's not good to put it into a paper because it makes things confusing. And people are not going to read it, or if they do read it, they're going to lose the thread of the paper. Put it into an annex. Put it into supporting information. whatever. Make sure that the contents are correct. Take a look at these numbers. We are talking about mean values with standard deviations. When I see something like 1.2 with a standard deviation of 2.2, this person is not serious. I'm not going to read this paper. Or if I do read it, and I don't realize what the mistake is, I'm going to have some false information. Today, you cannot be a good medical writer without some basic knowledge of statistics and basic knowledge even of mathematics. We learned that in 3rd grade, 4th grade, maybe 6th grade at the most. You cannot have a standard deviation that is greater than the mean. 2.2 is greater than 1.2. Not possible. You cannot have a minus value for the calcium. What this means is that the people that wrote this paper calculated the mean without realizing that the values for all the patients were not normally distributed. In other words, they did not correspond to the Gaussian bell-shaped distribution curve. And as such, they come up with the standard deviation that is bigger than the mean. Now, you can say, okay, well, so what? We know that there's 1.2 on day 1 for the non-anastomotic leak group and 2.6 for the other group. The p-value is 0.07. That's all that counts. No. When you have a normally distributed piece of information, there are specific statistical tests that correspond to that. And when it's non-parametric, you have specific tests that correspond to non-parametric information. So that p-value of 0.07 that was calculated using a statistical test that goes with the mean may not be statistically significant if you use a non-parametric test. I hope I'm making my point. So be very careful of the contents. When you put the content into a table, make sure that it corresponds to what you want to say and that it is methodologically correct. Make sure that the totals add up. Now, this is a very specific example that I showed because this is a paper that I corrected, so I know that the authors made a mistake somewhere during the process and they had to correct the numbers, but when they corrected the numbers in the text, they forgot to correct them in the table, and the totals don't come up to the same. Very poor medical writing. And once I see a paper like that and I see that there's a mistake like that, it takes away from the credibility. Remember my first slide today. Medical writing is to diffuse information that is credible. If you see a mistake like that, it means that the authors did not pay attention to the final result. They made a mistake, okay, everybody makes a mistake. But still, this information is out for approval, for diffusion, to be used by other people. It has to be precise. We have a not only a medical legal issue here, but an ethical issue of portraying correct information. And if we do not, we're not doing a good job as scientists. So be very careful when you write a paper, make sure, double check, triple check, I don't know how many checks to make sure that the totals go out, especially as in this case, where the paper was rewritten, recorrected, or revised, and the numbers were not changed. The difference in percentages was only 1%, but a difference of 1% can be enough to change a p-value. Okay, for tables, let's take a look now at figures. Figures are even more visual than tables, because you have the possibility of using graphs, whether they are line graphs or bar graphs, that are able to show tendencies. And that's very informative. The information that you get from a line graph or a bar graph, there's a visual aspect that comes shining through and complements the text. But there are also going to be illustrations, diagrams, photos, or even sometimes drawings. The figure titles and legends usually are indicated at the end of the manuscript, as for the tables as a matter of fact, after the references. And as for the tables, they have to be in Arabic numbers, indicated also in chronological order. Figures should have a short title, maximum of 15 words, bold font, usually no dot or period, but some journals put them there, as you see in the example. Today, the most commonly used figures are flowcharts, Kaplan-Meier plots, bars plots, what we call repeated measures, or pictograms. We'll take a look at some of these. The flowchart is the same that I indicated in my first presentation. It's actually a flowchart of the consort eligibility criteria. In other words, once again, going from credibility, the eligibility during the enrollment, with the randomization or selection procedure, and then we have the arrows that indicate the two groups going down and forth. Flowchart. There's another flowchart. Be careful when you have a lot of information that this is fairly well done. There's a lot of information. You have to read it very carefully, but everything is there. Kaplan-Meier plots are used from time to event or survival data. A typical example is shown here. Here we see that the spread is indicated by the light pink, whereas the red is the Kaplan-Meier plot. we have on the abscess axis the time, but we don't know what the units are. It should be indicated minutes or seconds or whatever. Here we have the cumulative event with the percentages. And every time you have a Kaplan-Meier or time to event, you have to know the number at risk for each individual piece of information. 1,584 for the time 0 to begin with. 1188 after the time unit 10, or whatever that time when it was, and so forth and so on, so that we finally came out with no survivors here at the end, or no patients left for whatever criteria we're talking about. Make sure that the scale is adequate. This is something that I found in the literature, which is, if I look at it very carefully, I'm going to say, okay, practically no difference. What's going on? I don't know what. It's not very much information. But actually, if we had an appropriate scale, we would see that there is a difference. And if you look very carefully, the 95% confidence interval, 0.6 to 0.9, does not cross 1. In other words, there is a statistically significant difference here. But if I look at this curve, I'm not going to see it. My visual impression is wrong. Another type of figure is what we call the forest plot. Interestingly, we don't know where the word forest comes from, whether it's because these graphics should look like a tree or whatever, or it was a Mr. Forest. Actually, we don't find any reference to where the word forest comes from, but that's another problem. Anyhow, forest plots have a numerical basis here, the number of patients in each group albumin over the total of 3,012. Albumin compared to saline. We have confidence intervals, 95% confidence intervals with the odds ratio. The odds ratio of 1 being indicated here. And then we have the numbers that correspond to what we see. We can see that they cross the 1 line, the odds ratio of 1, and none of these values are statistically significant. So we have a good visual image right from the start that gives us an idea of what we're talking about. Here are examples also of other forest plots with the diamond. We can use them for meta-analyses, but we can also use them for other types of comparisons, not only meta-analyses. Very indicative, very useful. Today, we see a lot of these, and we can see right away, well, now the numbers, there's no statistical significance here, but also if you look at the ratio here of 1, you can see that there are values here for the systolic blood pressure of less than 132. There is a statistical significant result here. And you see that 0.51 to 0.95 does not cross the 1 for the hazard ratio. Most often we use what we call repeated measure plots. These are useful for quantitative outcome measures at baseline, and then for more than one, in other words, 2 or more follow-up times. Make sure that you use different symbols for each treatment to help distinguish them. I'll show you an example. Here we have dots, and here we have triangles. Dots for surgery, triangles for non-operative care. You can follow the curves. You can see that they're fairly similar. Here the scale is okay. A problem with graphs, however, is what we call offset axes or truncated axis. Be very careful. On the left, you see a truncated axis between 50 and 0. There's no values. So there's no values there. So we can see that the two curves are fairly close together, each other, and there's nothing indicated less than 50. Not a problem. However, on the right, you see that the editors truncated the axis between 600 and 800. And the values that are here, we've lost the information. We don't know whether the black dot is 700, 800. We don't know where it is. We've lost the perspective. We've lost the scale. So be very careful. Truncate axis is only when there's no values. Don't truncate where there is value. Beware also of joining lines. Just because you have a graph, you want to have lines here. There's no reason that the true values could not be a curve here. We make the assumption, because we have one value for 0 and another value for 24, that there's a linear relationship. What we don't know, it may not be a linear relationship. In any case, by putting a line there, you as an author indicate that there's a linear relationship. So if there is one, okay. If there's not one, be very careful. Don't use it. Could have been something like this, as a matter of fact. And it might not even be appropriate. For instance, you cannot have, if you look at the y-axis, number of staple lines, you cannot have a half a staple line. The duration is a continuous value. That's okay, but the number is not a continuous value. Make sure that they correspond. Make sure that the order is clear. Don't use what we call area graphs. Area graphs are confusing. We don't know the product, is product B just this value here, or is it this entire value? When we see something like this, are we talking about the total value or the difference, partial value? But don't use area graphs. They're very confusing. They're ambiguous. When you have footnotes, use letters rather than symbols, and they should go after the title on the bottom. Let's take a look at the other types of figures. For instance, bar graphs, histograms. They are very useful when you want to compare the value of a single variable as it evolves through time or something like that, or as it's measured. For instance, a frequency. Make sure that there is not too many columns. Here you can use color. Prefer vertical to horizontal. And make sure that your legends are clearly visible, parallel, perpendicular to the axis. Here's an example, very good example. There's color, there's lines. The standard deviation is indicated. The p-values, the bars that are being compared are indicated. Very good. Very clear. A little bit more complicated, but still fairly clear. You can get all the information that you need. Pie charts also can be used. Problem with pie charts is you don't want to have too many parts. If you have too many parts, it gets very confusing. You want to be able to arrange the segments by size or by some other order. I believe that it's best to arrange them by size, the largest slice starting at 12 o'clock. I'll show you an example. Here is not the case. The largest size is here, 29.2%. It should have been ideally starting at 12 o'clock, but it's still pretty indicative. Here, the three-dimensional one doesn't add that much, but not too bad. Also not too bad. Pictograms are becoming more popular and they're very good. This gives a little bit of flavor to a graph that ordinarily would be just a bar graph. I talked about gender a little while ago. Also, this is very indicative of and attractive. Same thing for the location of the carcinoma in the liver. In this particular case, a pictogram. Much better than words. Bosk and whisker plots. Rock curves. Scatter plots. Gazintas, for instance, for a chemotherapy regimen. A block gazinta. Normograms. Many different types of figures can be used. What's important, however, is to make sure that you use the correct software. CorelDRAW perhaps is very widely used in some countries, but it doesn't work for Mac. PowerPoint systems are very good. Adobe Photoshop is very good, but try to use the information that is available and never use Excel once again. It's not compatible. You have infographics, but make sure that they're visible. Here we have a lot of information. Not so sure they're going to use that information. And sometimes you get things that are completely invisible, like this. I don't know who's going to look at it. No one's going to understand it. But be very careful. Don't overuse the figures. I've said this before. Make sure of conversions when you use something on the web, for instance, in resolution problems. I'll talk about that. It is possible today to use information off the web. This is a Google page, but it's in French, but you can understand, I'm sure. You have a tools section here. You go into the tools section, I'm sorry, you go into that. Okay. For some reason, it's not working. Maybe it's Zoom that's not allowing it to work. Let me see if it works this way. Here we go. So you see when you go into the tools, you have a pop-down menu, and you can see that there are images that are available with or without license. In other words, the copyright. So you can have this information and stuff, and you will realize you know whether you can use the image or not for your paper, whether it's reproducible without or with copyright. Make sure that your illustrations are well done. Make sure that the DPIs are correct. Good color. Sorry, I have to go a bit quicker, running out of time. Make sure that, for instance, this is completely inadmissible in our day and age, especially with the fact that the framing is awful. Figures, professional drawings only. Some papers will, some journals will even admit personal drawings. So just check. This is quite good, I thought. Okay, so I think that's for that. Sorry, I ran over a little bit over time. If you are available with some burning issues, some questions, I'll be more than happy to answer. Can you? Is it okay? Hello?
Thank you.
Yep, thanks so much.
Are there any questions?
So there are 2 questions in chat, but I think we've discussed that.
Okay.
Nastya, are there any other questions on the internet?
Okay, I'm sorry that I can't develop more the 2 drafts of the other papers, but what I will do is I will do some summary, some corrections and send them to and send them back to you so that the authors can get some feedback on that, if that's okay with you. Is that okay? Hello? Hello?
Hello there here. Thank you so much for your speech.
Okay, I hope everybody is happy. Next time, I hope we can do it in person, much better. But we'll work on it. Okay?
Thanks, Abe. Thanks much. Yeah, we've checked the internet. There's a lot of thank you comments and like overall things like it's really useful. So we will do our best next time to to invite the audience to really participate. And this is something that
it must be much better if we had some interaction.
Yeah. This is something that all our viewers need to take into account, and
Okay.
get into Zoom instead of just, watching it like a TV. But this is something very, very characteristic of Russians. Same as with the passive voice and,
Yeah, but it's
social distance.
Sure.
It's sometimes it's tougher to kind of to interact, but we will work on that. Thank you very much. This was really useful. There's a lot of thank you and this was useful comments. We had close to 100 viewers actually during the course, and I think we will bring you more statistics, and of course the recording will be available, so definitely 200 or 300 people will watch it in the recording.
Okay.
So thank you again very much for the course and for your attention. It was a real pleasure.
Okay, same here. Same here. Bye-bye.
Cheers. Bye-bye. Thank you very much.